So we're going to talk about nursing care of the child with an infectious disorder, an integumentary disorder, and or an immunologic disorder. I want you guys to focus on just doing your concept maps for each of the topics that I touch on. Something that's important to note is that infectious disease is one of the leading causes of death worldwide. Obviously, because we have vaccines available for a large amount of infectious diseases, we have seen the death toll decrease, but unfortunately, we have new diseases emerging. We just saw that with COVID, and then we're also seeing some other childhood diseases that were previously thought of to be eradicated rearing their ugly heads, like polio. So let's get going. So infants and young children are more susceptible to infection because they just have immature responses related to their immune system. They're going to have a decreased inflammatory response. So when a bug or a bacteria or a yuck or whatever gets into an orifice or a mucous membrane, their bodies don't have the same inflammatory responses that ours do, which trap it and try to wall it off and kill it. Theirs don't have that. So they're at an increased risk. They don't have a lot of exposure to new diseases because they're brand new. So they haven't created a lot of humoral immunity, which is the type that we create when our body comes in contact with or encounters something new and then develops an immunity to it. They don't really have a lot of exposure to disease, like I said, and they're starting to lose passive immunity over time that they're getting from their mother. So their risk of infection, again, higher. And most infants are not old enough to be immunized against all the diseases that they're going to come in contact with because of us. Their skin and their sweat glands contribute a lot also to exposure to bacteriums and viruses. Their epidermis is thinner than ours, and their blood vessels are closer to the surface, and they have less sub-Q fat. So this causes them to lose heat more readily through the skin, and we know heat kills a lot of viruses and bacteria. This also allows them to absorb things through their skin more easily than we do. They're more prone to blistering and skin breakdown because the epidermis is thin and there's less fatty tissue. Their skin doesn't have as much pigmentation as ours, so they're at increased risk of skin damage from sun exposure. And their temperature regulation is really not very effective until they're usually a middle schooler. So overall, they're just at a really much higher risk than we are, and then we mess with their risk by choosing not to vaccinate for whatever reason we might have. I want you guys just to make quick concept maps about these. Don't go crazy with them. Just quick concept maps. Simple, to the point. So we're looking at methicillin-resistant Staph aureus. Usually this is acquired in the community. The bacteria gets in through a break in the skin, dry skin with fissures or cracks, cuts, abrasions, lesions. It's transmitted through contact, through personal items, surfaces, blood, and respiratory droplets. We are going to put these patients in contact precautions. There really isn't a whole lot of reason to put them in contact precautions prior to the opening of the wound, but sometimes we will. The cues we're going to see: red, swollen, painful, hot, abscess type areas. It often starts with somebody noticing a swelling in the hair follicle, like near the groin or the armpit, or they have something they think is a pimple or a bug bite. Diaper regions, it's huge. Parents pick at little skin abnormalities in the diaper region. Their fingernail opens the skin and introduces nastiness, and then the next thing you know, you have a 9-month-old with a massively swollen labia and cellulitis that's extending all the way down her little tiny thigh. And then they have to have incision and drainage and packing, and keeping it clean is a whole thing. So we're going to diagnose this with fluid or pus from the abscess. We can't truly diagnose MRSA if there's no break in the skin or the wound has not erupted yet. Some of the nursing actions: we're going to control their pain with warm compresses. We're going to give them pain meds, antipyretics. We're going to educate them regarding hygiene and hand hygiene, the necessity of completing antibiotic therapy, and we're going to put them in contact precaution and make all the families participate in that as well. And we're going to tell them to not share personal items. Dr. Thomas, who used to be the favorite hospitalist at Memorial Hospital Pediatrics, he used to advise families of a child that developed a MRSA infection And when we're doing the family history, we find out dad has frequent infections or abscesses. We would tell them to take betadine that you can buy over the counter at Walmart, put 3 little tiny capfuls of it in your bath at least once a week, and wash yourself with that. And he would also tell them to put Neosporin in their nostrils daily. And this tended to decrease the prevalence of its passing from one family member to another. Scarlet fever, it's caused by a type of group A strep that produces a toxin, and then you shed that through your skin, and then you get the rash. Those that are most at risk for developing this are between 5 and 15 years of age. It is highly contagious, and it is spread through respiratory droplets. Some of the cues you will see are temps higher than 101, chills, nausea, vomiting, body aches, and a sandpaper feeling rash along the trunk and the back. It comes and goes based on activity, temperature spikes, and crying. They also develop a strawberry tongue and whitish spots in the back of the throat and the palate. Scarlet fever is diagnosed with a throat culture, and some of the actions that we take are to give penicillin or amoxicillin. Those that are allergic to penicillin have to take erythromycin. Usually this is given orally. And they provide comfort measures, increased fluids, popsicles, soups, use a humidifier, stress the importance of oral hygiene, keep these kids' mouths clean while they're dealing with the exudates in their mouth and the swelling, and throw those toothbrushes away. Impetigo, often mispronounced as infantigo. It's not. It's impetigo. It's a secondary bacterial infection that's caused by Staph aureus after you've suffered some sort of skin trauma. Tends to happen a lot around the nose and the mouth. I think of constant nose picking of those young kids with their dirty little bacteria fingers. Some of the cues that we will see, a hallmark sign of impetigo is a honey-colored crust that forms over the papules. The treatment is usually a topical antibiotic. Some of the nursing actions that we would want to take is to apply cool compresses to the area. This allows us to soak the crust off, and then you can apply the topical antibiotic over the top of that. Rubeola is just regular old measles. Rubella is German measles, and Roseola infantum is an exanthem. These are all really examples of viral exanthems, which basically means rashes. It's important for us to ask the family or the caregiver when the fever occurred as opposed to when the rash occurred, because this helps to point towards the appropriate diagnosis. And we ask about exposure, and we ask about immunization history. We are seeing an advent of these diseases rearing their ugly heads again because people have stopped immunizing. Our management is comfort and symptom control, and we're going to try to keep the skin intact and clean. For little ones, we might need to put mitts or gloves on them to keep them from scratching to the point where they open lesions and create more infection. There can be some complications of all of these diseases that require hospitalization, but most of these can be managed at home. Varicella, otherwise known as chickenpox. This is crusty little papular lesions, little vesicles that spread pretty quickly. Once you see one of them, you're going to see hundreds of them in less than an hour. So if you have a patient who the parents are suspecting chickenpox, but by the time they seek out medical care, the child isn't literally covered in these vesicles, it's not chickenpox. The incubation period for chickenpox is 10 to 21 days after exposure. So you could go up to 3 weeks without knowing you have it, and you are spreading it to everyone. It is communicable 1 to 2 days before the rash erupts, all the way through the rash, and 7 days after the rash has crusted over. There is a vaccine for this now, and it's transmitted through direct contact. It is also airborne, and it can be passed from mother to fetus. For our nursing management, we treat symptoms, and we try to provide comfort. There are times in adolescents or adults that they may treat with antiviral medications, IV fluid therapy, and antipyretics in the hospital setting because they run a higher risk of developing meningitic or encephalitic type of issues from varicella. This is called Fitz disease. If you've ever heard of parvovirus, parvo, and your dogs usually are the ones that have it. This is a human form of parvovirus. We don't spread it to dogs, and they don't spread it to us. We spread it to each other via droplets or from mother to fetus. Usually this is a daycare, kind of rampant daycare sort of situation. It has an incubation period of 4 to 28 days. So by the time you see this kid having the rash, they probably aren't really contagious and don't need to be excluded from school or daycare, but they still will be because nobody wants them there with a rash. The hallmark sign of Fitz disease is a slapped cheek appearance. So it looks like on both cheeks we've just slapped this baby. And they have itchy, kind of lace-like rash that spreads from, it spreads out peripherally. Get ready to get very itchy. So lice, head lice. It is also known as pediculosis capitis. The place that we see it the most when we are concerned about it, we might see what looks like dandruffy sort of spots on the scalp, but we're really going to be clued into this when we notice that the patient is itching constantly behind their ears and at the nape of their neck, and that tends to be where the lice are crawling around. We treat this with pyrethrin, permethrin, and removal of the eggs. We do put these patients in a hospital setting into contact precautions, and we ask them at home to clean and or remove their personal items. You can kill these sorts of nits and lice by placing your personal items in a sealed baggie and like putting it out in the sun. They'll die after a day or two. But good copious washing with hot water is great. Get rid of those brushes. No more. Get a new hairbrush. Scabies. That's a pretty little guy, right? So looks very similar to a mite. It burrows under the skin, and you can see the picture that's underneath this scaby dude. It's got a little hole and then a raised pile of lumps leading from it. So basically the scabie has burrowed under the skin through the hole, and it's laying eggs all along under the skin. And we tend to see that if we're concerned that the child or patient has scabies. If you look in between the folds of the fingers or the feet, this is usually where you see the entrance. and then the little path of egg laying. Scabies causes intense nighttime itching, usually in the folds of the body. So your armpits, groin, they really like warm, moist, dark places. The treatment it's the same as it is for lice, but we're putting it on your body, not your head. And they both do require repeated treatment. It's good to repeat the treatment for lice as well as for scabies once every 2 to 3 days times 2 to 3, depending on the severity. For scabies patients, they can, even after they've been successfully treated, still have itching. The management, obviously, contact precautions. We're going to treat family and sexual contacts prophylactically, and they need to thoroughly clean their bedding and clothing and personal items. Hot water cleaning with repeated washings. Yeah, I'm already itchy thinking about this. Pinworms, they are a helminth. They're the most common helminthic infestation in the United States, and the transmission is fecal-oral. You can pick this up a lot in sandboxes. So little kids playing in the sandbox, you know who else likes to play in the sandbox when nobody's looking? Cats. And they cover up their poo in there, and so do dogs. And then you get their dirty little fingernails of the kids playing in the sandboxes or in the dirt, and then those dirty little fingernails are picking their noses, and the pinworms basically get in that way. And then they find their way to the GI tract, and they start laying eggs, and they go nuts. And it is very itchy. These kids will have constant anal itching, nose itching, and it's always worse at night. One of the strangest things is that we diagnose this literally by sticking like clear tape on the anus at night, just right in between the butt cheeks, and then you peel it off, and there's usually pinworms stuck to it because they tend to come out at night and play around. So sometimes parents or doctors can even look at the anus with a flashlight at night, and you can see them moving. Yeah, it's beautiful. So we do have anti-helminthic medications, and we need these patients to practice a lot of good hygiene and do frequent clothing changes. And then it's helpful if they bathe in the mornings or shower in the mornings so that they can wash the eggs or the worms off their anus, which is super fun to think about, right? We're going to see a lot of inflammatory skin issues in children, especially in Kern County, because we have a lot of allergens in our air, and we also have a lot of allergens in our food, and different disease processes can create different changes in the pH of your skin. Diapers change the pH of your skin, and it makes you more likely to develop dermatitis. So with diaper dermatitis, you can see a huge range of different presentations. It can be red, it can be shiny, it can be dull, it can be bumpy, scaly, oozy, it can be very dry appearing. Redness is typically how we start. It is helpful to determine whether or not it is a dermatitis that is being caused by a yeast and the inflammation related to that, or if it is literally just an inflammatory response. So we're going to treat these kids with barrier creams. We want to tell parents to avoid soaps and fragrances. Just use water. to clean them in the diaper regions. Let them air dry. In kids that get constant diaper rashes that are hard to treat, one of the best things you can do is just let that kid be on a Chucks or a towel, cover up. I pull the towel up between their legs and lay it loosely over their belly, and they can poop and pee in it if they want to, but it allows them to have more airflow, and they tend to clear up the diaper rash pretty quickly. One of the things we need to educate parents about is that baby powders are not actually for babies. You should not use baby powders on babies at all. Don't do it. You cannot keep that powder out of their tiny little respiratory tracts. And those that are at a higher risk for diaper rashes and dermatitis, they tend to be children who also are at a higher risk for allergic rhinitis and asthma and other breathing issues and eczema. So keep the baby powders out of the baby room. Really, there's no reason for it at all. It's not good for adults and it's not good for babies. So no baby powders. Eczema is also known as atopic dermatitis. It is an inflammatory response. The risk factors for atopic dermatitis or eczema are that you're a male, often black or dark-skinned, with food allergies, allergic rhinitis, and or asthma. So for children with eczema, we need to watch for signs of secondary bacterial infections, like superimposed infections. They're going to be so itchy and scritchy, and they're going to be scratching with their little tiny nails, and they're going to be so uncomfortable, and they're going to break open their skin, aside from the fact that it is dry and scaly and will break open often on its own. So they're just at a higher risk for secondary infections. One of the ways that we educate parents is to not bathe these kids in hot water, like throughout their lives. They should not soak in a hot bath. They should not take hot showers. It's only going to exacerbate the inflammatory response. We want these kids to air dry. So when they get out of the bathtub or the shower, you can pat them a little with a towel, but mostly just let their body absorb the water. Apply medicated creams that are usually prescribed by the physicians. There are a lot of creams that have steroids in them. It is really not a good idea to use steroid-containing creams on a regular basis. Those should be used sparingly, especially in growing skin and on the face. And eczema tends to occur a lot on the face. So if they're being prescribed steroid creams, it needs to be an infrequent thing. So after they've applied their medicated cream, then you're going to kind of hold that in by applying a moisturizer over the top of the cream, like Vaseline or Eucerin or Aquaphor, something thick. And then give the kids antihistamines at night and try to do as much distraction from itching as you can. Keep their fingernails short and well filed, and try to keep them clean and dry. Systemic lupus erythematosus is an autoimmune disorder that is multi-system, meaning it affects many different organ systems at once. It is usually diagnosed between 15 and 45 years of age. It is very difficult to diagnose. The risk factors are being female. It occurs 4 to 1 female to male. And in adolescence, it's 9 to 1. So it's not likely to see this in males after adolescence. Systemic lupus erythematosus is more commonly diagnosed in African Americans and Hispanics, and they have more severe effects from the disease. So this is an inflammatory response that leads to vasculitis, which leads to injury to the tissues and pain. So the systems that are most affected in children are the blood, the skin, and the musculoskeletal system. It's common for them to experience a lot of fatigue, fever, weight changes, pain in their joints, prolonged bleeding, photosensitivity. We're going to see cues of what's called a malar rash, and that is a butterfly-shaped rash that's over the cheeks and the bridge of the nose, and changes in their skin pigmentation overall. That we're going to be assessing their joints for edema. If they have renal involvement, which is also common, they can have hypertension, and we're also going to want to watch their BUN and creatinine for their kidney function. They can develop a lot of visual changes and ocular complications. They can have cerebrovascular accidents. Like I said, it can affect their kidneys. They develop glomerulonephritis. They develop pericarditis and heart disease in the valves and coronary artery disease. They can have seizures and develop psychosis from microvascular changes in the brain. When we do diagnostic testing, we're looking at usually seeing a decreased hemoglobin and hematocrit. The platelets are usually affected. The white blood cells are affected. And we look for a hallmark diagnostic test of an ANA, or the anti-nuclear antibody. We expect that to be positive, but they've actually, evidence-based practice or evidence-based research has shown that that is not always the case. There is a large number of people who suffer from systemic lupus erythematosus who do not have positive ANAs. So we're going to treat these patients as nurses. We're going to treat them for inflammation and tissue damage that's creating chronic and acute pain. So some of our goals are going to be to improve their comfort level. We want to give them warm compresses. We want to give them massages. We want to change their position frequently. We want to allow them to rest. We want to give them supportive mattresses and foam mattresses and pillow support, splinting of those painful swollen joints. Teach them some different relaxation techniques and to provide them with activities that divert their attention. We're going to provide them with anti-inflammatories and analgesics. We're going to try really to encourage them to express their feelings. Having chronic pain and a chronic illness, especially diagnosed when you are young, it really sets you apart from your peers. And it's hard as you grow to constantly meet people and hear from people who want to identify your disease with their own lives. So they will frequently come up and say things like, oh my goodness, my best friend's sister has that. And you know what? She totally fixed it by using a keto diet. And if that was the case, then no one would have lupus. Everyone would be fixed by now with a keto diet. So it becomes over time just a constant barrage of people telling you how to fix yourself and not realizing that this is chronic with acute flares. It doesn't go away. The only things that we can do is manage it over time and hopefully decrease some of the complications that are likely to occur. These patients are going to have a lot of mobility impairments and fatigue. So we need to make sure that they are able to maintain optimal mobility. So we want to make sure to encourage them to tell us what they need as far as mobility. How likely do they think they are going to be able to walk around an amusement park? Encourage them to let their family know, if I go to Disneyland, I need a wheelchair. Assess the need for occupational therapy, physiotherapy, and we're going to talk to them about going to see podiatrists for orthotics that'll help their feet, and how to speak to someone in occupational therapy and physiotherapy about correct posture and body alignment, and how to maintain your mobility by stretching. We want to help them identify obstacles in the environment. So kind of the same thing that you learned probably in your fundamentals with helping the geriatric patient in their homes or facilities, that we want to remove rugs, tripping hazards, curbs and little steps, things of that nature, lots of clutter. Those sorts of things we need to identify in their environment and help them to remove it or change it. And we're going to try to allow them to have lots of time to perform their activities and to rest after doing them. That's really important. So when we're treating lupus, and I believe you can find this information on page 1861 in your text, but we treat them by managing the inflammatory response. We give them NSAIDs, corticosteroids, and frequently there's anti-malarial agents that are used. So these are like hydroxychloroquine that I'm sure you guys heard a lot about with the advent of COVID, and some strange anecdotal evidence on thinking it treated it. That's jury's still out there, but it does help to treat the inflammatory response in lupus. And they also use Plaquenil. They give, for severe lupus patients, high dose corticosteroids or immunosuppressive drugs. And the reason those are given is because the belief is that the immune system in your body is overacting to every little tiny interaction in there. If we suppress your immune system, then we suppress the complications that would arise from the vasculitis and the tissue damage and the end organ failure. So some of the nursing management for lupus patients is that we want to educate them about trying to maintain a healthy diet, trying to maintain some regular exercise. That does not mean going to the gym 3 times a week and lifting weights or doing extensive cardio. Lupus patients might need just regular exercise that includes walking or some non-weight bearing exercise. We want them to get adequate sleep, good rest. We need to have them avoid lengthy periods of sun exposure and to judiciously use sunscreen, because they're going to get a lot of rashes. They're going to be very photosensitive, and they frequently have flares after having had some extensive sun exposure. So someone's parent goes to their graduation in June and they have to sit outdoors, and the graduation takes 4 hours, and then 2 to 3 days later they're exhausted past the point of being able to function. They're feeling nauseous and vomiting. They're experiencing excessive joint swelling and pain, and they're having a lot of times a lot of visual sensitivity as well. And all of it is because they were out in the sun for too long. We want to protect these patients against cold weather. They tend to often have a manifestation that's called a Raynaud's phenomenon, and that is a vascular issue with your hands and feet. Look it up. It's pretty interesting. So we, anyways, want to protect them against the cold weather, and going from one extreme to the other of cold to hot, it causes a lot of inflammation. So we want them to layer with warm socks and use gloves in the winter. We also want them to have yearly visual screening exams, eye exams. They need to not just be seen by an optometrist, but also by an ophthalmologist. It's not helpful to just have the visual screening at like lens crafters. They need to be seen by an actual ophthalmologist. We're going to give these patients NSAIDs and corticosteroids, like I said. One problem is that these patients often have to have a large amount of corticosteroids over the course of their life, and that can lead to a condition that's called avascular necrosis, which is a lack of blood supply to the joint that causes tissue damage. So anytime the family or child has a new onset joint pain that is out of their norm, that is not manageable with their normal pain management regimen, they need to let the doctor know so that it can be looked into to make sure that they don't have avascular necrosis. This slide is just a breakdown of the different types of medications that we would use to treat a lupus patient, and some of the considerations we have to take. Like that with the corticosteroid, if they're using an oral, they need to have that taken with food to decrease their GI upset, and that we need them to understand if they've been on it for a long time, it might mask the symptoms and signs of an infection, and they need to monitor their blood pressure. We also treat, like I said, with the non-steroidal NSAIDs. Diclofenac is a common one, ibuprofen. This again, these patients do suffer a lot from a lot of gastric upset and some GI bleed sometimes because of frequent use of NSAIDs. Diclofenac can be especially hard on the stomach. And we want to monitor their liver enzymes because we're messing them up with all of the NSAIDs. We also treat them, like I said, with anti-malarial drugs like hydroxychloroquine. And we need to make sure that we check their visual field and their eyes as far as a fundoscopic examination of the eye, because this medication can create some issues in the eye itself. We also use cyclosporine, another med called azathioprine. We use methotrexate frequently. If they are taking the immunosuppressives like cyclosporine or azathioprine, cyclophosphamide, these are medications that you will often see patients taking after they've had organ transplant. So these drugs, they're pretty heavy. They can be given by mouth or by infusion, and they cause a lot of side effects: nausea, vomiting, hair loss, bladder problems. They decrease the fertility of the patient. They increase their risk of cancer. They increase their risk of infection. And the longer they're on these treatments, the higher their risk for side effects is. So it's really important to monitor these patients very closely while they're on medications, because even though the medications are treating them to try to stop disease progression, they're causing other problems at the same time that can also be life-altering and or life-threatening. So juvenile idiopathic arthritis, you can find this on page 1863 in your text. This is an autoimmune disease. Autoantibodies target the joints in particular. There are a couple different types. I don't need you to know the difference. I just need you to know that all of them can involve the joints, usually the knee or the small joints. They all can involve the eyes, creating complications of iriditis, iritis, uveitis. I've had all of those. They're also going to have malaise or just fatigue in general, poor appetite, issues with basically looking like a failure to thrive when they're little. Um, they're they're often going to have lymphadenopathy, and they rapidly progress to a disfiguring type of joint involvement. They could have fever, rash, splenic enlargement, liver enlargement, severe anemia. So for the nursing assessment, the cues that you're going to see in these patients, it's going to be pain, redness, warmth, stiffness and swelling of their joints. Stiffness is usually worse in the morning, and can last anywhere from an hour to 2 or 3 hours after waking. They tend to have a limp, and they can, like I said, develop pulmonary fibrosis, pleurisy, pericardial effusions, and pericarditis. We need to work with these patients on slowing their disease process, controlling their pain, maintaining and or improving their physical mobility, and the fact that they are likely going to have some delay in growth and development overall from not just the disease itself, but also repeated hospitalizations, lack of interaction with other children, and time away from school. Again, just as a reminder, please make concept maps for all of these. Don't focus on writing every little thing down. So for juvenile idiopathic arthritis, the medical management, we use steroids, we use NSAIDs, we give them anti-rheumatics such as methotrexate, which is considered a DMARD, a disease-modifying anti-rheumatic drug. We want to provide them with support groups and emotional support, and really going through the importance of utilizing occupational and physical therapy and maintaining their range of motion and their muscle strength. Swimming is a super great way to do that. And we want to try to allow them to participate in normal life as much as possible and to attend school as much as they can. Obviously, we're going to have to work with schools for these patients and their families to try to get them more access to a plan for the times that they are not able to be in school. It shouldn't, every time they are gone from school, it should not be a mad dash to try to figure out which teachers have to submit which, assignments and what do they have to do to make up the time, things like that. It should be a well-made plan at the beginning of every school year. We also want to do a lot of pain management for these patients and explain that, they can't try to overlook their pain and hope that it'll go away. They really do need to treat it. They also can use non-pharmacological pain management, like taking warm baths before they go to bed, utilizing warm compresses or heating pads, using ice if that's what makes them feel better. We also tell them that it's a really good idea to have spares of everything. Don't make the child carry their books in a backpack that's super heavy. They're probably not going to be able to handle that. So they need to have 2 sets of books, one that stays at school, one that stays at home, so they don't have to carry those things in a backpack. They might need to carry with them like a little chair pad to be comfortable at school when they're sitting, and the instructors need to know that they might need to get up more frequently and move around.